Welcome to the ASBrS 2025 presentation, a fork in the road, a multidisciplinary perspective on current and future applications of minimal residual disease in breast cancer management. This session explores the transformative role of Signatera, a tumor-informed MRD test, in guiding personalized breast cancer treatment. Join our presenters, Dr. Angel Rodriguez, breast medical oncologist and medical director at Natera, Dr. Erica Giblin, breast surgeon at Ascension St. Vincent, and Dr. Alice Ho, radiation oncologist at Duke Cancer Institute, as they share insights on leveraging circulating tumor DNA, ctDNA, to optimize patient outcomes across neoadjuvant, adjuvant, surveillance, and metastatic settings.
All right, good evening, everybody. Thank you for joining us tonight on an evening where we're gonna chat a little bit about MRD and the field in breast cancer. My name is Angel Rodriguez. I'm a breast medical oncologist and senior medical director at Natera. And joining us today are Doctors Erica Giblin, a breast surgeon from Ascension St. Vincent in Indianapolis, and Alice Ho, radiation oncologist at Duke Cancer Institute. And so today we'll be talking about fork in the road, multidisciplinary perspectives of current and future applications of molecular residual disease management in breast cancer. So just to have an idea of today's agenda, we're going to talk a little bit of an overview of Natera and Signatera specifically. We're going to review and discuss both data and current and future application of Signatera and MRD monitoring in the neoadjuvant and adjuvant settings. And we're also going to talk about the data and applications in the surveillance setting. And then we'll save time for a Q&A. But first and foremost, we need to talk a little bit of truly why are we here? Why should we care about MRD? Why are we wanting to learn about this? And the reality is that, as we treat our patients with breast cancer, we understand that there are challenges and there are needs that haven't been met yet. And one of them, on the left-hand side, is the fact that, thank God that many treatment options do exist, and very effective treatment options that have reduced the risk of recurrence in many of our patients and improved survival. But the truth is that knowing which patients need intensified or more treatment, extended therapy, versus which patients may be safely spared treatment, may be given either less treatment or at least not have to undergo or not be referred to trials to do more treatment, that's unclear. So to be able to have a tool that can help us refine which patients have better outcomes than others is something that is in dire need. In the middle is the fact that, well, sometimes when we do our best, right, we do our best with local management, surgery, radiation, and systemic therapy, sometimes our best is not good enough. And unfortunately, up to 30% of patients with breast cancer will eventually experience a relapse. So to have the opportunity to identify who those might be at a very early stage and potentially have the opportunity to intercept what would ultimately translate into death is using a test that can reliably identify who those 30% of the patients are can be very beneficial. And I'll stop and I'll mention something about these two sort of blocks on the left, and that is essentially when you think about this tool, molecular residual disease testing, you have two results. It's either positive or negative. It's either favorable or unfavorable. It's rising or it's not rising. And essentially when it's unfavorable and rising, that's what we're talking about in the middle, right? When these results mean that this patient is at significantly high risk of recurrence, significantly high risk of death, then we should do more. For what purpose? Ultimately, to improve survival, right? We shouldn't be doing more unless we're improving survival. And on the left-hand side, when it's about you also have a negative result. So in the negative result, we're not going to improve survival by giving less treatment, but what we have to do at least is improve quality of life, reduce toxicities, reduce financial burden. So essentially, think about those are the main things that in the MRD field we're trying to accomplish. And then finally, yeah, on the right-hand side is the fact that, as we know, which is tied to the middle box, is as patients eventually develop relapse, in today's practice, as you all know, intensive surveillance strategies is not recommended in 2025 by the guidelines. And we'll go deep into this as to why that is the case. But essentially, previous strategies that have been tested have been proven to be ineffective. Ineffective, because it's shown that there's no improved survival, but also ineffective because the tools used were inaccurate. And so those are the things that we're going to address today. But first, for those of you who may be new to understanding what it is that we're doing here, we're identifying circulating tumor DNA, right? So all of our successes, many of our successes in oncology in general, have been because we've exploited the weaknesses of cancer. Essentially, this is another weakness of cancer: the fact that it gives itself away by shedding some of its genetic poop, if you will, into the blood, and we can then detect it in the blood with this technology. ctDNA essentially becomes an ideal biomarker because of its very short half-life. And actually, we know this because we're a company experts in cell-free DNA. We have prenatal testing. We are able to evaluate how long does a Y chromosome live in a woman who's just given birth to a baby boy. And we know that it takes very short amount of time for the DNases in the body to get rid of that. So, when a patient has had surgery, if a week later or two, we see evidence or fragments of DNA in the blood, it's not because it's residual from what you took out a week or two. It's essentially because active disease is actually still there. So, what is Signatera, and what does it mean to say a tumor-informed molecular residual disease test? Back in 2000, roughly 2014, is when the liquid biopsy technology started making it to the clinic. And the purpose of these biopsy tests was to identify genetic alterations from the cancer in a patient's blood and not have to sequence the tumor, which in some cases can be really hard to obtain bone biopsies and sequence it. Essentially, it was a blood test to detect DNA that came from the tumor in the blood. Those technologies are currently used today in the metastatic setting and are very easy to extract and detect ctDNA, essentially in cases where the burden of disease is very high. So when the burden of disease is high, the tumor DNA in the blood is high, and it's easy to identify, characterize, and sequence those. Now, when those tests were used, we realized that can we actually use that kind of test to detect molecular residual disease in the blood? And the truth is, they're not sensitive enough. When the levels became too low, kind of like a CAT scan, when you do a CAT scan and you don't always see disease, but recurrence eventually happens, essentially the same thing happens with those kinds of tests. So the approach to improve upon the sensitivity or detection of ctDNA comes in this fashion, where we take a sample of a patient's tumor tissue and we take a sample of the patient's blood. We sequence the tumor DNA, roughly 20 to 30,000 genes, and we sequence also the patient's germline blood, right? What variants or what sequencing the patient was born with. And then we can compare and contrast and develop a unique signature of tumor mutations for each individual patient. Essentially, we then take those mutations and we convert it into a relatively simple multiplex PCR assay, which is essentially detecting, amplifying, and characterizing the DNA with this test that we can do then periodically over time. The first test, when we do the sequencing, takes about 4 weeks. Subsequent tests, just a week to get answers. And now we have a personalized assay that's used. Essentially, this is what the test looks like, where on the left-hand side, you see the levels, and in this particular patient, you see the burden of disease go down over time and reach undetectable levels. But of course, that's what we call the analytical validation of the test, right? That the test can be reproducible, that we can detect DNA. But the second super important step when you have a test like this is you got to do clinical validation. Very fortunate to have worked with collaborators around the world where samples of patients' blood after curative intent treatment were collected periodically and stored to be analyzed at the right time. We were able to go to many of these institutions and providers and convince them that we think we have a technology that can identify which patients are at risk for recurrence. And essentially, that's what you see here across 8 different cancer types where the test has been validated. Patients who have undetectable ctDNA over time are unlikely to experience a recurrence versus patients who have detectable ctDNA at any time point during the course of their sort of surveillance period experience a very high risk of recurrence. And specifically in breast cancer, right? First, many peer-reviewed publications that have spoken about that have talked about these different indications in the neoadjuvant, adjuvant, surveillance, and metastatic setting. We're going to go into some of these this evening. And also, we have obtained coverage in the neoadjuvant, adjuvant surveillance, and in metastatic setting in immunotherapy. Essentially, what this means that we have proven to Medicare that we have a test that has a significant prognostic value, and that if in the clinical setting, if a physician, if a team of clinicians deem that the test is can reasonably determine a patient's management, Medicare is willing to cover for it. I want to highlight that obtaining this coverage doesn't mean that we're done with proving further testing the technology in patients. At Natera, we are committed to generating high-level quality studies to ultimately, whether it be randomized clinical trials, single-arm studies, ultimately to prove that our patients are better managed when the test is used. And then finally, some of the key sort of clinical development use cases are early response monitoring. We're going to highlight this evening in the neoadjuvant and treating on molecular relapse. And before handing it over to Dr. Alice Ho, who's going to talk to us about first about neoadjuvant foundational data, what are the questions, right? What are the opportunities that we can potentially use to improve the care of our patients? Well, first, in the neoadjuvant setting, can we assess early on with this sort of blood molecular tumor burden, identify patients that have better risk or high, good risk or high risk, and start thinking about either de-escalating, for example, in triple-negative breast cancer? Can we avoid anthracyclines in some of our patients that are getting immunotherapy and chemotherapy? Or in scenarios where the treatment just seems to be futile and it's not working, switching to a treatment earlier on. I'll mention, of course, as you know, there's data out there coming out now that potentially de-escalating surgery, may be an option for de-escalation. And so, can ctDNA dynamics potentially improve upon the selection of patients who may safely avoid surgery? And then optimizing adjuvant therapy. I think that's one of the most important ones. Where can we identify patients who truly benefit from CDK4/6 inhibitors, who may not need ovarian suppression, right? Or may not have to go into sort of additional therapies. As right now, as we speak, treatment is escalating with clinical trials that are happening, and before we know it, more treatment will be offered to some of our patients based on a 2 or 3% improvement. Do we really need to give it to everybody when there's a small improvement? And then finally, in the surveillance setting, identifying accurately, detecting relapse to enable escalated imaging in the right person. So with that, I'll hand it over to Alice to talk to us a little bit about the foundational data in neoadjuvant setting.
What's the down? The down is
Just
this one. Okay. Okay, So thank you, great to be here. I would love to speak to you about Signatera risk stratification, specifically in the neoadjuvant treated breast cancer patients. So, yeah. So I'm sure all of you are familiar with the ASBrS trial. It's a trial that was designed to really test in a high throughput fashion a variety of agents and in terms of whether it would influence pathologic complete response compared to standard of care in various types of breast cancer, but most specifically in triple negative and high risk HR positive, HER2 negative breast cancer. And so there were 4 very specific time points that were utilized in ASBrS, and on the basis of this trial, these are the 4 time points that many clinical trials, as well as off trial in the clinical setting, is recommended when you're thinking about when and how to order the ctDNA. So if you're thinking about, well, if I'm going to do this and how would I deploy it, there are 4 neoadjuvant time points to consider as done in ASBrS. One is at baseline, of course, before you start any sort of neoadjuvant therapy. Now, time point 1 is the early time period where right after 1 cycle of chemotherapy, a blood sample is obtained, and then right in between AC and TC, that mid-chemo cycle is time point 3, and then finally that 4th time point is right after all neoadjuvant therapy is completed and prior to surgery. So those are the 4 basic time points. As you can see by the publications here, since 2020, there have been major studies involving Signatera in breast cancer used in the neoadjuvant setting. And these are all studies that all started very simply, where the concept is designed, the blood is collected at these 4 time points that I mentioned, and they're stored until they're ready to be analyzed. And patients were most often treated in the context of a clinical trial. I myself used these time points when I designed radiation trials after neoadjuvant therapy. So after the trial is done is when the outcomes are often assessed. And so you can see, if you look at the sample sizes among the different subtypes of breast cancer patients, that with time between 2020 to 2023, on the very right, the sample size is getting larger, and that just demonstrates the growing adoption of ctDNA and being more comfortable utilizing this in the clinical setting. This is a very seminal 2023 publication that demonstrates how pretreatment ctDNA is highly prognostic. You have 2 cohorts of patients here, high risk ER positive or HR positive and HER2 negative, and triple negative. And notably, all of these patients had high mammogram scores. But if you look over on the bars on the left, you can see that 69% of HR positive, HER2 negative breast cancer patients have ctDNA that's detectable. And in triple negative, that percentage is even larger, 91%. So what's interesting is, irrespective of the biological subtype, on the right-hand side, those with undetectable ctDNA at baseline, you can see had much better outcomes than those who had detectable ctDNA at baseline. So again, we go back to these 4 time points, with T0 being baseline, T1 after 1 cycle of chemotherapy, T2 mid-chemotherapy, and then T3 right before surgery at the end of neoadjuvant therapy. And again, for HR positive and HER2 negative and triple negative breast cancer, you see 3 lines here. The top one showing a pathological complete response with negative ctDNA at time point 3, right before surgery. Obviously, these patients do the best. Next, you have patients who don't achieve a PCR, and you can think of them as either having ctDNA positive detectable levels at that time, or negative levels. And to no surprise, you can see that irrespective of the biological subtype, those who did not achieve a PCR with detectable ctDNA had much worse prognosis. These were all, again, high-risk stage 2-3 patients. So I wanted to go into some real-life case studies and just talk to you a little bit about how I've been able to slowly incorporate the use of ctDNA into my practice. In general, these are very general indications for being willing to order ctDNA. I also find that even without these indications, many of my patients increasingly have heard of ctDNA and asked me about it. And over the years, I've gained some comfort ordering it in these settings. I think it's always good to have your own personal guidelines in terms of where you think that this could be very useful. So residual triple negative or HER2 positive disease after neoadjuvant therapy.
Say next slide.
Sorry. Residual triple negative or HER2 positive breast cancer after neoadjuvant therapy would be one indication, especially in those who have RCB2-3 disease. Whether to radiate, give post-mastectomy radiation or regional nodal irradiation in the 1 to 3 positive nodal setting. As surgeons and radiation oncologists, we know that this is very much a gray area with attempts to use other assays to really figure out who's low risk and would not benefit. And I find that those patients who do not want radiation being monitored with ctDNA is also a very useful kind of biomarker to follow them. We have those patients who are early stage hormone receptor positive, HER2 negative breast cancer patients where often they seek to de-escalate care, whether that be radiation therapy, and there are even those patients who don't want endocrine therapy, even though when they omit radiation, we of course encourage them to stay on endocrine therapy if possible. So although they're very low risk, I do find it a very useful biomarker to follow those patients when they're doing something that's not quite evidence proven yet. Many patients, as we know from the Keynote 522 trial that demonstrated that the addition of pembrolizumab to carboplatin and anthracycline-based chemotherapy improved PCR as well as survival in triple-negative breast cancer patients. When they achieve that PCR, and that's 65% of patients, it's an open question right now whether they should continue to get pembrolizumab in the adjuvant setting. And so there's an Alliance optimized PCR trial that you may be aware of where patients are being randomized to either receive pembro or not in the adjuvant setting. But for those patients who are not participating in that trial and really don't want to continue pembrolizumab, as obviously there are tremendous side effects with immunotherapy, I find it very useful to obtain ctDNA as surveillance in those patients. And then of course we always have those patients who want to try quote-unquote alternative medical pathways, but who still desire to be followed. And you certainly don't want to abandon them, and you want to work with them. And so I found that, interestingly, ordering ctDNA in those patients have proved to be very useful, and it's really served as a way to really work together and find a way to come to an agreement about what that treatment pathway should be. So this is a real-life case of mine. It's a young woman, 45 years old, who was diagnosed with a clinical T2N2 triple-negative breast cancer after presenting with a 4-centimeter palpable breast mass. Imaging, including the breast and axilla, demonstrated a 5-centimeter spiculated mass in the right upper inner quadrant of the breast and multiple axillary lymph nodes that appeared suspicious for malignancy. The biopsy of the breast mass primary as well as lymph nodes demonstrated invasive ductal carcinoma that was triple negative, and staging workup was negative for distant metastasis. So this is a patient who was offered the Keynote 522 regimen, in other words, immunotherapy and chemotherapy, but she was hesitant to really try that, dive into that right away, and really brought up this, this proposal to try mistletoe therapy, which of course I knew nothing about at a holistic medical center. So instead of abandoning her and saying, I'm not going to work with you, that's not possible, and that stuff doesn't work. She wanted to know, well, are there other ways you could follow me? Are there other alternatives? And of course, ctDNA popped into mind. And I said, well, look, like, obviously we are united in this goal that we'd like this cancer to stay away. And I understand that you want to try something different before going into something conventional. So how about if we order a ctDNA which is going to tell me how high the tumor is shedding its DNA in your bloodstream? Why don't we try that right before you start mistletoe therapy, and let's put a limit on this mistletoe therapy. Let's say 3 weeks max. And then let's try drawing a ctDNA again, and let's see how well that your tumor responded to mistletoe therapy. So she agreed to try this, and sure enough, before beginning mistletoe therapy, her ctDNA level was 25, but then, then after 3 weeks of therapy, that ctDNA level rose to more than double what it used to be. And so seeing those numbers were really valid for her, and she agreed to start conventional chemotherapy and immunotherapy, and was very gratified to see that those levels would drop down. Whoops.
Yeah, I'll do that one.
Okay.
Okay. Thank you, Dr. Ho. So I wanted to update you this evening as well on this newer data, actually, that was recently presented and soon to be published. And this is now sort of additional patients cohort that goes up to now 720 cases, and adding right what was we didn't have before, more patients with HER2 positive disease, and essentially, right, those initial observations that I presented earlier today, do we see the same type of prognostic importance in this larger cohort? Right, as I mentioned, the I-SPY2 had trials showed patients with residual cancer burden 2 and 3 after neoadjuvant chemotherapy who tested negative, either during or after treatment, had significantly lower risk of recurrence. And so for this portion of the analysis, the utility of serial ctDNA monitoring to improve risk stratification in this residual disease risk and high-risk disease was examined. So again, essentially, these patients that have residual disease, like today in the clinic, you have a patient with triple negative, 2-3 centimeters, chemotherapy is given. You tell them that they initially have about a maybe 20 to 30% risk of recurrence, and then they come back after chemo and they have even more disease or even higher risk of recurrence because they had a residual disease. Can we identify which of these patients maybe do not have as high a risk of recurrence? So essentially, starting off with 778 patients, after being able to analyze the patients with samples, 723 patients, 2,800 plasma time points. Basically, the characteristics are noted there, very similar to what we see in the practice. The main thing to understand is that these are patients that either had high MAPRIN score if they had hormone receptor positive HER2 negative, or of course, triple negative or HER2 positive was enough to participate in the study. So the first thing that we see is, well, what we expect, that if we stratify patients after they've gotten neoadjuvant chemotherapy, if we stratify them by the residual cancer burden, those who have the highest burden of disease have the worst outcome. Those who have the few amount of disease have the best outcome, or PCR essentially in the blue. And if you haven't seen it, there's a new JCO publication that essentially, to simplify this residual cancer burden, which is like a calculator that not too many people use, there's a sort of a suggested new or sort of novel staging system in patients who receive neoadjuvant chemotherapy that essentially shows the same thing. Small burden of disease, lower risk of recurrence, higher burden of disease, higher risk of recurrence. So first, let's look at those patients who have a intermediate to moderate high risk of a burden of disease on the left-hand side. So residual cancer burden 2 and 3, which is, again, 2 centimeter residual disease, lymph node residual disease. So essentially not PCR and not patients that have less than 1 centimeter of disease. What this is showing you on the left is that if some of these patients, approximately 20% of these patients, can have undetectable levels of ctDNA, and as Alice mentioned earlier, it's essentially about 30% of ER positive and about 15 to 10% triple negative, and about 15% of the HER2 positive. So if they have undetectable ctDNA at baseline, they have a 98% 3-year disease relapse-free survival, RCB2, and 94% for RCB3. So essentially, really, it's those patients that had detectable ctDNA at baseline that had truly are at risk of recurrence. And then at the right-hand side is those patients who, if they didn't clear ctDNA at all, that's just trouble. That's in the blue line and the red line. Those patients, yeah, they go through surgery and they may get additional adjuvant therapy, but essentially the risk of recurrence is actually quite high. But also, you know, and this is the key things to understand, to know, right? And this is what the future holds for this type of monitoring of patients is, number one, what their baseline status is, positive, negative. Number two is, if they're positive, how quickly did they go to negative, right? That first cycle of chemotherapy, essentially that's telling us how chemosensitive that disease, that biology is. So what you see in the green, yellow, blue, those are the patients whose ctDNA went quickly to 0. Those are the patients that also have a good prognosis. Versus patients who are in the red or in the purple, those are either they didn't clear ctDNA at all, or they cleared the ctDNA, but it was only at the last time point that cleared it. So essentially, it's telling you it's a stubborn chemo-resistant disease. So here's an example of how, you know, we may view things differently in patients. So here's a patient, 41-year-old, T3N0, grade 3 metaplastic, triple negative breast cancer, essentially deemed to be sort of high risk of recurrence. They received the neoadjuvant chemotherapy. They still do have residual disease. So that first time point, second time point, as you see that the levels went down, the fact that it didn't completely and quickly went to 0 kind of gives you a sort of a ballpark idea that this patient has sort of an intermediate risk of recurrence compared to this other patient that after just one cycle, you know, the ctDNA went down to negative. You know, what's interesting when we compare these two patients, you know, one that is relatively higher risk and this one, which is lower risk, this one ended up going into a clinical trial, right? And so in the future, we foresee that knowing these dynamics, it will be better for us. It'll be better able to kind of stratify these patients. Who should really be thinking about we need to do more versus who needs to do less. Yeah. So essentially, yeah. So I'll give you sort of a sneak peek. Also, in a couple of weeks at ESMO Breast, we'll be presenting not just whether it's positive or negative, but the levels of ctDNA. Are the levels of ctDNA at diagnosis, can they be prognostic? And at what level should we be worried? At what level can we be optimistic about what the patient's outcome is going to be? So stay tuned for that. And another super important one will be at ASCO, which is assessing whether the ctDNA can predict the nodal burden of disease, and could that potentially influence our surgical management. So stay tuned for ASCO. And if you don't get a wind of it, please reach out to us. We'd love to share with you that data. Now we'll move on to the surveillance setting, and of course, right, the criticisms of the evidence informing surveillance guidelines in breast cancer include the fact that these studies were conducted in the context of imaging and therapeutic interventions that were available at the time. So essentially imaging that was not as good as what we have today, imaging that could be susceptible to false positive detection of disease. And so now, obviously, we have much better tools that can be more accurate. The second point that is highlighted in this review is that also these studies were done, you know, before some of the more effective therapies that exist today. So it essentially questions whether, you know, it at least leaves the door open for can intensive surveillance and identifying disease recurrence earlier potentially improve the lives of our patients. And then finally, like trade-offs, and I'll have Dr. Erica Giblin talk a little bit more about this. But essentially, what they do sort of leave the door open for is that we now that we know that we have these current deployable strategies, whether it be scans, blood, MRD, ctDNA, engaging patients in a shared decision-making, clearly conveying goals, expectations, and the limitations of the evidence will be super important as we deploy it in the clinic. And so, as evidenced by this, current guidelines, although they don't recommend active surveillance, the adoption has been quite high over the last several years. And initially, it started off in the later surveillance, and it is trending towards earlier and earlier initiation of deploying the MRD strategy. And I'll talk a little bit about the foundation data that we validated the test. So again, very fortunate to have collaborated with this institution in the UK, where they did in surveillance in patients treated with breast cancer and collected samples periodically with long-term follow-up. And essentially, the study showed that, first of all, that first time point after they completed curative intent treatment, and of course, these patients did not have any further change in therapy, right? They either started their endocrine therapy if they were ER positive or triple negative and HER2 treatment, respectively. If they were positive, these patients ultimately all had recurrence of disease. But if they were negative on that time point, they had significantly lower risk of recurrence. And with serial testing and serial monitoring, more of the patients that recurrence would have been identified over time, and patients who were persistently negative had reduced risk of recurrence and better survival. And so this study, which was presented last year at ASCO, is a multi-institution study that deployed ctDNA testing in the clinic, and essentially looked at what were the outcomes when these patients who were surveilled, what happened to these patients. 464 patients underwent surveillance testing. 12% of those patients ended up having ctDNA positive results, which prompted the clinicians to use this as a high risk of recurrence, leading to imaging in 45 of those patients. Approximately a little more than half of the patients, recurrence was detected on scans, including local recurrences. And in 20 or 44% of those patients, the testing with the imaging was negative. There was no evidence of disease yet. But within those 20 patients, there was still an opportunity to optimize therapy within standard of care guidelines, such as switching to an aromatase inhibitor, adding endocrine therapy if it wasn't there yet, or adding CDK4/6 inhibitors. And so in this small study, small subset proof of concept, essentially it showed that of these 9 patients, 5 of them cleared their ctDNA, 4 of them who remained imaging negative to date. This is essentially kind of like a guideline of how sort of the decision tree of deploying the test. First, talking to the patients, the pros and cons. Patient says no, pursue current guidelines. If it yes, then you could pursue standard monitoring with, again, that shared decision making. If the test is negative, continue as is. Patients should remain on treatment. As is today's current standard of care. Not yet are we at a point that we can say that if you're negative, you can safely stop treatment. But if it is positive, again, consider optimizing therapy if it hasn't been optimized yet. A scan should be considered, whether it be looking for local recurrences or systemic imaging. And if disease is not found, as I mentioned, optimize systemic therapy, potentially refer to clinical trials if it's close to you. And then if a recurrence is diagnosed, of course, treat it accordingly. And so with that, I'll pass it on to Dr. Erica Giblin, who will speak a little bit about her experience.
Okay, hi guys. I'm the token surgeon. So I have a very busy clinical practice. I practice in the community. And as all of you, I'm sure our work days are long. So I don't have time or energy to change my workflow or clinical practice unless there is a reason to do so. So a couple years ago, I had a survivor. She was post-op. It was a grade 1, 3 millimeter IDC, ER positive. And I was talking to her post-op about surveillance. And I'm like, okay, we're going to see every 6 months for at least 2 years. You'll get your mammogram, going to get your MRI. And I was just going through what we do as our workflow. And she paused a beat, and she looked at me, and she said very clearly, not good enough. And I looked at her, and I was like, holy crap. And I'm like, what? And she's like, not good enough. She goes, "You're going to follow me just with pictures twice a year? How do I know my cancer is not going to be coming back?" And that made me think about survivorship when I see the patients. It doesn't even matter if I've seen them 2 years, 3 years, they're doing great. They are terrified. Every time I walk in the room with a survivor, you can feel the fear. It's palpable in the room. So that made me start thinking, what can I do to benefit survivorship, not only to detect if a recurrence is happening? That's not enough. Like just giving somebody bad news? I mean, that sucks. How do I move the needle? How do we actually change it where we can help these people perhaps live longer? And that really rang home more recently because I'm sure all of you are seeing this. Younger women are getting breast cancer. I'm seeing 20-year-olds, I'm seeing 30-year-olds. My partner a couple months ago had an 18-year-old. They are not BRCA. Cancers are rising in the young. Childhood colon cancer has risen by 200% in the last couple of years. So cancer is now affecting the young. These people need to live longer. They have families. This is going to affect multiple generations. So that was my impetus for adding Signatera to my workflow. I'm going to go through a few cases to show you why I think this test is beneficial. So the first one, standard 40-year-old woman comes in. She palpated a mass. This one was in the right upper outer quadrant. So she got the standard diagnostic workup, mammogram and ultrasound. And those both showed a 2.4 centimeter mass, and she had a lymph node, cortical thickening. So core biopsy shows grade 3 IDC with lobular features, hormone positive, HER2 negative. The node was positive as well, so metastatic disease in the node. I did an MRI on her. The disease was 3.4 centimeters, and she had satellite nodules right around the primary lesion, and she had multiple abnormal level 1, level 2 nodes. Her PET was negative, oncotype 25, so she got dose-dense ACT. So she subsequently underwent mastectomy. She did have residual scattered 6 centimeters of an IDC with lobular features within a large amount of scar from post-neoadjuvant treatment effect. 3 out of 8 lymph nodes were positive for metastatic disease. So she underwent post-mastectomy radiation therapy. She then had her ovaries removed and started anastrozole and abemaciclib. Now here's the thing with surgeons. So I follow my patients every 6 months. A lot can happen in between the time that I see them post-op and 6 months. So what I didn't know was in between the time when I saw her and saw her next, or saw her post-op and then saw her next, is she was having a lot of diarrhea on the abemaciclib, she was having ankle swelling, and then she went through her second stage reconstruction with deep flap, had a few complications with that, with wound healing issues, and that whole entire time, months, her abemaciclib was held. So I had no idea about that until I saw her Signatera. So she's been getting her Signatera blood draws all along, and all of a sudden it popped positive. So I called her up and I said, your Signatera is positive, which means we are having a recurrence of your breast cancer. Have you been on your medical therapy? And then she broke down crying. She goes, no, I was having issues with it. I had my deep flap. I've been off of it. And I told her, first thing is, let me get a hold of your medical oncologist. It is a team. The team is going to discuss, and we're going to figure out what is best medical management for you, and is there any other pictures we have to get? So I'm trying to walk her off the ledge and explain to her logical workflow that we're going to do to A, identify what's going on, and then B, manage it. So talked with the medical oncologist. They ordered whole body imaging. That was negative, thank God. And they flipped her to ribociclib, which she tolerated a heck of a lot better. At that time, after her positive Signatera, we started following her Signateras every 8 weeks. Why did we do that? Well, we wanted to see what change of therapy did it A, stabilize, or B, actually start a downtrend. C, it could do an uptrend, which then we have to really think about what we're going to do for her. Thankfully, as you can see here, it started to do a downtrend. So we are going to continue to follow her with Q8-week Signateras to see if that downtrend does go back to 0. So this was something for my clinical practice. I wouldn't have even known about her being off the therapy and the sequela of that without having this blood test. So this actually changed her medical management. Now here's another one. So this one, we're getting older in age. 48 years old. She had a mammogram. She had a 1 centimeter nodule. Actually 2 of them. Right 10 o'clock and right 12 o'clock locations. Had core biopsy of each. The first one, 12 o'clock, was grade 2 invasive lobular cancer, hormone positive, HER2 negative. The 10 o'clock was an IDC with lobular features, once again, hormone positive, HER2 negative. So she went to the OR, got lumpectomy and sentinel lymph node biopsy, 8 millimeters and 1.1 centimeters of invasive lobular cancer, respectively, and 2 out of 2 sentinel nodes were clear. So she went on to get her adjuvant radiation therapy. Oncotype was 21. She was going to start anastrozole, but I'm sure you all have this. When you talk to the patient post-op, you're like, you're going to do your radiation, you're going to do your anastrozole, right? And they nod their heads dutifully like they're going to do it. This one didn't. She skipped her med-onc appointments and she ghosted us, right? But here's the thing. She got her blood draw, okay? So initially her Signatera was negative, it then spiked to positive. So I called her on the phone and I said, we haven't seen you in a hot minute, and we now have a positive Signatera. Your cancer is recurring. Are you on your meds, your anastrozole? And she was honest, she goes, no. I go, well, you know, we have a very important point in time right now where we have to make some very big decisions which could either help you or hurt you. What do you want to do? So I also told her I'm going to once again talk with medical oncologists, similar to the last patient. This is a team approach. How do we adjust your management? How do we maximize things so that we can get that number to go back down to 0? So in talking with her medical oncologist, once again, similar to the last patient, we're going to repeat Signatera every 8 weeks to see stabilization, downtrend, or uptrend, okay? If the numbers rise, right, bad juju, what do we do? So in talking with the medical oncologist, obviously want to ensure adherence, make sure she's postmenopausal, and then we got the options for medications. Are we going to throw a CDK4/6 inhibitor with an anastrozole adder? Are we going to change the anastrozole? She didn't want to take that, so do we change and go to letrozole? Do we go from anastrozole to tamoxifen, or do we put her on a clinical trial? So at least we have a plethora of options to offer to her. What do you think, medical oncologist?
Yeah, and I think what's interesting about this case is technically the trials where you could initiate a CDK4/6 inhibitor in the adjuvant setting, patients could initiate it up to 1.5 years after they had their surgery, right? That's just how the protocol was written. So, you know, one could argue that even in this scenario, even after like 3 or 4 Signateras, which could still be within 1.5 years, you're still within, you know, where there's data that is proven that CDK4/6 can reduce the risk of recurrence. I think when you get to the far out range of 4 years later, 5 years later, you know, that's where the trials are happening now to see if indeed, if we start CDK4/6 inhibitor later on, if we can reduce it. But this case would be one that the reason that we give offer CDK4/6 inhibitor is not, there's nothing fancy predictive about a lymph node being positive or it being grade 3. It's because the risk is high. It's because the risk of recurrence is high. And that's what the positive Signatera is telling you, that her risk of recurrence is high.
Yeah. And I will say one thing just from being a surgeon with these patients is when I do call them with a positive result, it is amazing how all of a sudden they fall into line with medical compliance. Absolutely amazing. Now, another one, 57-year-old female, once again, palpated a new mass, upper outer quadrant, this time on the left, 2.3 centimeters. The core was a grade 2 IDC, hormone positive, HER2 negative. Took her to the OR, lumpectomy. She had a 3-centimeter IDC with lobular features. Once again, 2 out of 2 nodes was negative, okay? So she had a Signatera drawn. This one I did at the post-op visit. I missed getting it when she was at her new diagnosis visit. So at the post-op visit, her Signatera was positive. She's completely asymptomatic. No headaches, no bopaids, not jaundice, none of that kind of stuff. The medical oncologist said, let's get a PET on her, let's figure out what the heck's going on with this positive Signatera. And unfortunately, she had several PET-positive lesions in the bones, several foci in the ilium. She had a focus in the right proximal femur. So here you can see the trend line. So Signatera was positive, flamingly positive. She had her PET scan done. We saw the bone mets. The medical oncologist initiated ribociclib and letrozole, and then we followed the trend line. While we were following the trend line, 3 months after starting the medications, they repeated her PET scan, and the iliac bone SUV went down to 3. That's great. And the femoral bone lesion wasn't even seen. And then we followed this again with repeat imaging once again, 3 months later, didn't see anything. And her Signatera, as you can see here, dropped to 0, and we are still following that. So there was a direct change in medical management based on this finding. We would have not PET scanned her on her initial workup based on the type of lesion she had in the stage that she initially presented with.
Erica, let me jump in on that case. That's actually very useful. That's a very useful case for radiation oncologists as well, because when you have oligometastasis, there's always the dilemma of whether radiating up front in an asymptomatic patient is useful or not. And you know, the studies are conflicting. There's one that shows the NRG study demonstrated really no benefit to radiating oligomets, especially in the HR-positive, HER2-negative patients, but other studies, such as the SABRE-COMET, have demonstrated there's some benefit, although SABRE-COMET did not have a huge percentage of breast cancer patients. So I think that holding on radiation if it's asymptomatic, but watching the ctDNA levels, and if you see them going down on systemic therapy, it's reassuring for the radiation oncologist who wouldn't feel the need to jump in there and radiate.
Yeah, absolutely.
And I would add one more point. If you show the picture of the pelvis, like one has to wonder, what this would have looked like had it not been detected asymptomatic. Sure, pain, but possibly a fracture.
Fracture, yeah, absolutely. And I know some of you have seen those fractures. They could be agonizing with these people, a lot of pain. Okay, so 7-year-old female, screening mammogram. Once again, a 1.1 centimeter asymmetry, right up outer quadrant, core biopsy, grade 1, invasive ductal cancer, hormone positive, HER2 negative, looks like a nice lesion. Right lumpectomy, it was a 1.5 centimeter, they upgraded it, grade 2 IDC, and she had 1.5 centimeters of surrounding DCIS in the specimen. Margins were good. Now she's 70, per Society of Surgical Oncology guidelines. I didn't do a sentinel lymph node biopsy. She was good, she got her adjuvant radiation therapy done, but she said heck to the no on doing an ASTROZOL. Her echotype score was 3. So I got her initial ctDNA, it was 0. So she asked a question a lot of patients ask, Doc, ctDNA is 0, why do I need to repeat it again? In 3 months or 6 months, make up whatever number you want. And that is a very good question that they ask, and I tell them it is a snapshot of a moment in time on whether or not there is tumor cells circulating in your blood. Is it possible there could be a sleeper tumor cell that's not shedding into the blood, but it's just sitting there quietly, and then one day it wakes up? So that's how I explain to the patients why we're doing these serial monitoring tests. And this is her. It was initially 0, then it popped positive. It was low positive, but it was positive. So I called her and I said, your cancer's recurring, unfortunately. What do we think about that in ASTROZOL again? So she said, absolutely. So she started on the anastrozole, we followed the trend line, and as you can see here, it's gone down to 0 and it has maintained at 0. So that was a direct change in management with this person as well. So here's my workflow, okay? It's different for everybody. She was very selective about her workflow. I encompass everybody. So all patients who come into my office as a newly diagnosed breast cancer, I will talk to them about offering ctDNA surveillance. Time 0 will be done within a week of the new diagnosis visit. Now, patients have the right to say no. This is a shared decision making. Do I have patients tell me no? They don't want to know. Sure, then heck, I'm not going to order Signatera on them. If they say yes, we get that testing ordered with 1 week. If it's negative, my practice in my clinic is I will test them every 3 months for 1 year based on the patients I just showed to you, especially the hormone positives. That disease terrifies me now more than triple negative or HER2 positive. So I'll test them every 3 months for 1 year, and then after that, every 6 months thereafter, for as long as the patient is willing to undergo testing. Now, what if that initial ctDNA is positive, time 0? It's a new diagnosis. They haven't even had any therapy at all. If it's positive, then after completion of the breast cancer treatment, me and the medical oncologist talk, and we discuss the result, and we see if medication needs to be optimized or changed. And if that's the case, Signatera is ordered every 8 weeks to monitor if the ctDNA levels are decreasing, stable, or increasing. If they're decreasing, we monitor them until they go to 0. If they are not decreasing, then we have to put our detective hats and figure out what the heck is going on in the body. So then we order whole body imaging. So that's my workflow for these people.
Yeah. So I wanted to also share, right, this was presented in San Antonio last year, right? One question that we commonly get is, this causes anxiety, or not even a question, just the assumption that this causes anxiety, and it's the reason why I wouldn't order it. And as Dr. Giblin mentioned, this shared decision making is very important, because what we've learned from other cancer types is the more you educate up front, then the less you'll be faced with anxiety due to what am I going to do with the positive. And so these are 3 studies, one done at Rutgers, Yale, and Pittsburgh, that looked at patient-reported outcome. Essentially, one showing most patients valued the information they received through Signatera testing, and over 90% would continue testing. Second one showed that no association between positivity and anxiety or distress. And the third one, nearly 90% thought that ctDNA could help inform their treatment decisions, and they were not anxious about receiving such results. Now this is small numbers, and larger studies are being done where we are, continuing to evaluate patient-reported outcomes, which is super crucial. And this was this one of your cases, Erica?
Nope.
Okay. Treating on molecular ASBrS quality of life and patient outcomes. So this is one where patient had grade 2 ER positive, HER2 negative, had completed a neoadjuvant chemotherapy. After several months, patient had discontinued hormone therapy, and that's when essentially the test was deployed and was offered to the patient. And again, you also have to think about how exactly do we prove that patients that are not adherent, right? That it's about 20%. Just recently was another sort of JCO article talking about the problem of not adherence and the potential of how we could reduce recurrences just by somehow enhancing adherence. And in this scenario, this is exactly what happened. A patient eventually on the third time point tested positive. Patient was put back on treatment and what had been previously recommended, ribociclib, and the patient converted back to negative, knock on wood. So far, so good. And then just to kind of to finalize the evening, we as I mentioned, we do sequencing. We also do sequencing of germline blood. Hereditary testing is a test that we offer. Empower. Many early breast cancer patients may be eligible for hereditary cancer testing. So please, evaluate your patients and consider Empower for your patients. And yeah, we do have hereditary testing alert programs. Are eligible patients being missed? This is something that we can deploy within your clinic. We identify patients that are eligible for targeted or risk-reducing therapy, predict response to therapy such as platinum chemo, eliminate risk for developing new cancers, and basically inform surgical decisions. And I want to share, this is another actually poster, we sent it last week. With the volume of data that we've generated to date, we've been able to do studies like this one, which are also very important. It's genetic ancestry-based differences across gene mutations stratified by tumor type. So essentially what you see here is side by side, and each color is the prevalence of specific tumor mutations that we found in the tumors of either African genetic ancestry or European genetic ancestry, and essentially we do see significant differences. So this is kind of just the tip of the iceberg of what kind of sort of novel scientific sort of discoveries we may be able to do with the fact that we're now sequencing both germline and blood on all of our patients. Yeah, I wanted to share with you a couple of upcoming presentations. Stay tuned. This first one, predicting nodal burden after neoadjuvant chemo with circulating tumor DNA for surgical planning, results from I-SPY2. It'll be presented in early June. Another one that I wanted to highlight was ctDNA. So most of the data I showed today was about neoadjuvant chemotherapy, and now for the first time, we'll be showing data on neoadjuvant endocrine therapy. Yeah, this week on Friday, Friday, feasibility of detecting ctDNA in malignant phalloides tumors and ctDNA dynamics. Very interesting stuff. So stay tuned. And then finally, the one a couple of weeks from now is looking at the pre-ctDNA levels to predict recurrence in patients with high-risk early-stage breast cancer. So with that, couple of clinical trials that are open. This is just a small smattering in patients with ER-positive molecular relapse, both in the US and Europe. And thank you. Thank you for attending. And we can take... So we're available for questions. Dina, I don't know if you have a mic that you can share around in case anybody has questions. And we'll be around a week. Oh, we got some questions here.
Oh yeah, okay, conversation with patients. That is one of the most important things. I don't get into the very granular details with the patient. You know, this is obviously a civilian coming off the street. So what I'll talk to the patient in those types of scenarios is if this is molecular recurrence, their PET scan's negative, or it's a very low level Signatera, so we're not expecting to see anything on imaging, medical oncologists may not even want to order it. I will tell the patient, similar to what I told you on the one patient that I presented. Breast cancer is smart. It is sophisticated. And a tumor cell can be wherever it wants to be in the body, and it can be sitting there sleeping, and it can wake up, and it can be floating through the blood, and the patient doesn't feel it. They are asymptomatic from that standpoint. It doesn't mean that they don't have breast cancer, right? So I sort of will talk to them in those types of terms, in terms of that type of dialogue. Does that make sense to you? Okay, I don't get into the nitty-gritty. It only scares them. They don't understand it. I don't tell them that there's been trials with early stage breast cancer and they did bone marrow biopsies and 30% of the patients had tumor cells in the bone marrow. Do you know what I mean? Like I don't go into those kinds of things with the patients. I will just say that breast cancer can sit there. It can have a little house, and one day it walks out of the house and it's floating in the blood. You know, but we don't know the house is there. We don't have enough technology to see that it's hiding there. Yeah.
I'll add that molecular recurrence doesn't necessarily mean that it's distant. It can come from local recurrences, it can come from the primary tumor, and it can come from distant.
I do it a little bit differently. I notice Erica, in true surgeon fashion, is very direct, and when the ctDNA becomes positive, you have a recurrence. I don't quite phrase it that way. What I say is, you know, breast cancer, it's something that we're always going to be fighting. We have a bunch of weapons, but we need to know when to pull out what weapon to keep it dormant. You know, but it's going to pop its ugly head at some point, and before it becomes a problem that really affects your life, and hopefully before we can see it on a scan, we want to get rid of it. So, about managing expectations. When you sign up to get this test drawn, is it possible that it could become positive one day? You may see a number that's not 0. Yes, that's possible. You know, so I feel like they need to know that up front. But the whole reason why we're doing this is when that number comes back, be it what it may be, but if you're being compliant and we're doing this regularly, hopefully we get that number back when it's a low number, because you need a lot of data points to see which kind of trend you're going in. If we can intervene faster, we can catch it earlier. And it's just first principles of oncologic management. Whenever you catch the disease burden at its lowest point in time, that's when you have the best chances of success with your systemic or local treatment. And so I say the same thing, but in a little bit different way.
And also letting them know the first Signatera may be positive, setting them up for that, you know, and just going through that may be positive, but we haven't completed our treatment yet. Let us do what we need to do. Let's see if that trend line goes down to 0. That would be my expectation, is that's where it should go. But you may be positive from the get-go, but that's okay. We're going to do treatment to get you to 0. So it's trying to also manage expectations, keep everybody calm.
And I noticed those studies showing lack of anxiety. You know, some of them were in older women. I have found that the way younger women with, you know, very bad disease up front, and 70-year-old plus who may have less aggressive disease or even aggressive disease, I do think that age kind of, naturally impacts how anxious one is going to get about that. And so, especially in younger women who want to be aggressive, who want double mastectomies, who want to do everything, like they need to be here for their kids and years afterwards, like having that talk is important. I've had a young woman get mad at me when I go to them and say, okay, the ctDNA came back positive. Oh my gosh, what does it mean? Like, why didn't you tell me this before? Like, everything is forgotten. But when you turn it around and you intervene either with a clinical trial or escalating treatment appropriately. And when they see that number start to go back down, it also serves to be very useful for them emotionally at that point. They know that their treatment is working, and it gives them a sense of comfort. And so, as with everything, there's a good side, there's a bad side, but you have to kind of take it in its wholeness.
I can't tell you the number of patients that told me thank you after having a positive result, and then we changed management, and then seeing that number go down. They were actually very thankful.
I've got a couple of things. First, initially, we thought that the negative at diagnosis meant the tumor wasn't shedding. Have any of those ever turned up positive on down the road? And the second thing is, in people who don't respond to their initial chemotherapy, neoadjuvant, and you do surgery, this is a reasonable way to assess their response to whatever second, third, fourth, fifth, 27th line therapies after you've done their mastectomy and there's no tumor to measure. I thought, that's a place we haven't had a good thing, and that's going to be useful going forward. But the not shedding,
So yes to both.
That's a different tumor.
Yes to both. So remember, the ctDNA in the blood is really a composite of the burden of disease, right? So, and also the biology of disease. So you can actually have tumors where the burden is relatively high, but the biology is so indolent that the ctDNA may be either at very low levels or undetectable. Now, although those patients have a lower risk of recurrence than those who have a positive, those that can be negative up front and have a large burden, you saw that residual cancer burden 3, those start off negative, but yes, eventually they may still experience a recurrence. And I think that reflects what we know about the biology of breast cancer, that sometimes it's there, it goes to sleep, it goes dormant, and something wakes it up 7-8 years later. And it has the opportunity to turn positive in the future. Yes, we've seen that.
Thank you. Just adding to that, I've had patients with residual disease, triple negative, after neoadjuvant chemotherapy, where the ctDNA, it stayed low-level positive on consecutive draws, but there was never anything that showed up on imaging. And so even for triple negative, we all know it's a very heterogeneous disease. I think the biology really definitely matters.
I have 2 questions. So one is, do you have an idea what your false positive and false negative rates are? I had a recent patient who has known metastatic lung met, who had a negative Signatera test a month prior. And then number 2, do you know how earlier intervention with change in therapy affects survival?
So the first one was, your first question was about?
False positive is false negative.
Yeah, false positive. So if I reference published data, so in the Monarchy clinical trial where a retrospective ctDNA analysis was performed, the way that we determine false positive is, hey, did we detect ctDNA and how many did not recur? Well, in that study, after 2 years was the final blood draw that was analyzed, and there were 72 patients that were positive at that time point. All of them recurred. So in that study, we did not see any false positive, but the reality is that false positive can occur, and they can occur for several reasons. False positive can occur there is rarely technical reasons, right? And that's actually less than 1% of the time, much less than 1% of the time that a test can actually be positive. It's like 99.8% positive predictive value. So very rarely, you can find a technical false positive, very rarely. Clinical false positives is something that we really gonna have to keep an eye on, especially as we develop this technology and we start going deeper and deeper in terms of the potential sensitivity. As you know, Erica mentioned, right, disseminated tumor cells in the bone marrow can be seen in patients who never experience a recurrence, right? So if this technology is gonna go down to detect those types of diseases, right, that are dominant in the bone, then we may get there. Now, with our tests, we see very, very few false positives, very few. Now, if that is ever, if there's ever a concern, that you have a case where, and maybe you've followed them for a while, or maybe that first time point you question it, you can call us and we can kind of give you some guidance.
So what about false negatives?
False negatives, a couple of things about false negatives. Remember, the way we do our technology is we sequence the tumor, and that's what we're looking for. So in the rare scenario, and it's not that uncommon, that a patient has multiple primaries, right? If we sequence one of them but not the other one, you could have a false negative result. Now, in those scenarios today, and we actually have the opportunity that if you have a patient with 2 distinct tumors, we can actually perform 2 Signateras to minimize that. False negatives, although rare, right, our sensitivity, you saw our serial sort of testing sensitivity to detect recurrence is in the range of about 94–95%, right? So whether that 5% is potentially related to, in some cases, very low indolent biology, small tumors, CNS disease, right? The sensitivity may not be as high as 94–95%. But it certainly is high enough that the test could be beneficial in the clinic. And I think your last question was, does early intervention lead to better outcomes? I would ask you back also, I don't know that for specifically in these patients that we talked about, 30% of the patients that are not adherent, just putting them back on treatment, will that mean that they're going to improve outcome and survival? I don't know the answer to that, and I don't know that we'll ever do a trial that we're going to randomize those patients, number one. Trials are ongoing. I showed one that called the EORTC TREAT ctDNA trial. In that study, patients who have completed at least a year of endocrine therapy and are monitored are essentially randomized to switching to a new treatment, which is what you're referring to, in this case, an oral SERD, versus continuing endocrine therapy. That study will be one that will help us elucidate that question. And there's another trial, the DARE trial, is also looking at whether adding a CDK4/6 inhibitor, and sometimes as late as 3, 4, 5 years. In triple negative, you'll hear soon about a study called PREDICT-RD, which is, and in that study, we're actually not randomizing patient. So we may not necessarily, right, because now we're begging the question, is it even ethical to randomize patients that are ctDNA positive to no treatment? But in that study, single arm, patients will receive a new drug, antibody drug conjugate for molecular recurrence of triple negative breast cancer. And there are many others. I could go on and on.
I was going to ask a question very similar to that. I applaud you on the density and the multiple studies that you've done on this. And the question is this an indicator or a method to prevent recurrence? The first time you treat the patient, whether it's neoadjuvant or surgery, you can see that the ctDNA goes down. And when it recurs, you're saying we should chase that with something to lower it again. But does that second episode have an impact on survival? Or is it just monitoring it, and as soon as you stop treating, the patient's or anyhow? So
great question. The best answer that we have or the best data we have to answer that question is in the monarchy ctDNA analysis, where approximately 40% of those patients had received neoadjuvant chemotherapy. Now, there we didn't have neoadjuvant time points. We would have expected many of them to go from positive to negative. But then what we do see in that study is that there were a significant number of patients had detectable ctDNA after surgery. And that's a study where we know an intervention was done. In this case, it was a CDK4/6 inhibitor. And actually, half of the patients got it because it was a randomized trial. And so 20% of the patients had prevention or sort of clearance of their ctDNA without ever experiencing a recurrence up to 4 years later. So it is the first kind of proof of concept that although a positive result is associated with an unfavorable prognosis, interventions can modify that prognosis. And in this case, CDK4/6 inhibitors. We have other data about chemotherapy. Soon, there's a study that's going to be published pretty soon. It was presented as an abstract. I don't know if you've remember the Beatrice study? It was a study that gave chemo plus Avastin. So that actually, what ctDNA analysis was performed, and it showed that ctDNA can clear and recurrences can be prevented.
Thank you.
So my question is there a benefit from repeating the test? So if a patient was previously negative and now is positive, hesitant in changing the therapy, and she asked for repeating the test, is there a benefit?
Yeah, I think it depends on the scenario, I would imagine, and what potential intervention you were able to switch to. Ideally, if it's positive and you still don't have evidence of recurrence, ideally you achieve, like in some of the cases described, that level goes back to negative. And so at a minimum, you'd like to see that, right? That it cleared. But you could make the argument that if it was positive and you found the clinical recurrence already, then you could argue, okay, what is the benefit of ctDNA in the metastatic setting? And for the sake of time, we're not going into that, but there's a lot of data also of monitoring patients in the metastatic setting as well. Repeating immediately to verify? Yeah, good question. Is that right? Yeah, good question. Actually, especially for ER positive, HER2 negative, where, now that we're detecting molecular burden at a very low level, we're now really also starting to see and understand that there may be inherent biological fluctuations that could make those levels sometimes flip-flop, go positive to negative. But the truth is that all the data that you saw today and that we presented, and a lot that we didn't present today for the sake of time, if you ever find a positive, even if the subsequent one turns to negative, that is a significantly high risk of recurrence. What we have demonstrated too is that having a positive that either flipped to negative or is slow rising is associated for a longer time for that recurrence to happen. So it's good news within bad news. So, having news that, okay, disease is there, but knowing that the velocity of that rise is not fast, tells you, hey, it's a favorable indolent disease.
Yep. I always tell patients when they become positive, you can't just rely on one data point. We may not decide to act on it right away, depending on what the situation is and what options we have. But you need a second data point in order to see what that velocity is. And that also gives you time to order the imaging along with it. And I think you need more than one data point. I mean, to me, I feel like you can't just stop. Like once you get that positive, even if you choose not to do something until you get a handle on what's going on, you kind of need to assess it.
I'll make a point too that people sometimes ask, right, at what level will we see things on scans? And it depends. We can see recurrences on imaging at any level. At any level. Now, percentage will be lower if it's a low level versus if it's high in the 10s and 20s, higher chance of actually finding something on a scan. But the mere fact that you can find it on any level should tell us that a positive result is a strong sign of recurrence. And just like guidelines do say, if you have a sign of recurrence, a symptom of recurrence that you should consider evaluating for recurrence, on any positive, imaging should be warranted. What you certainly don't want to miss is a local recurrence, right? As we all know that has definitely a second chance of cure, and this technology can detect local recurrences.
I have found it to be a struggle to get a PET scan approved by insurance companies often, and for example, your patient with stage 1 disease and nodal negative, my first thought was actually that would be a fight to get a PET. So have you found that a positive Signatera is sufficient evidence in most of those cases?
So far, yes. So far, yes. They haven't fought on it. We've had a few, it's been a few, where the insurance companies have refused the PET, but they have covered CT scans, bone scans first. So that is the other avenue. And that is covered, yeah.
I mean, it truly should be viewed just like, somebody who's high risk of recurrence and has abnormal LFTs that may have been drawn for some reason, that is considered a sign of recurrence that should prompt imaging. And so, you're right, it may take some education, and we do that, but it may take some education, to let them know that yes, a positive result is a strong sign of recurrence. But I hear you, there are challenges. I've seen them myself, yeah. I understand.
We know.
I understand, yeah.
We know.
I hear you.
Yeah.
I think especially if you're not informed about it before the test, I can absolutely see that, right? But the truth is, just like when we do proper informed consent for genetic testing, and just like initially when this panel testing came about, like pre-testing counseling was crucial. So as long as that conversation sort of encompasses what we're getting ourselves into in terms of what are the possibilities, Dr. Giblin mentioned, hey, it might be positive, and if it is, this is our plan. This is what we would do. This is what we should expect. So, Dr. Giblin,
Absolutely.
do you want to elaborate on that?
So, with the patients, it's all about setting the whole stage for them. Okay, because you're right. The emotional burden of cancer is PTSD for patients. Come on. So it's setting the expectation that you have a team. Your team is going to design a plan individualized to your care if this is positive. We're going to figure out what's going on. We're going to do our damnedest best to determine what do we need to do in terms of medications or medical management to get this to go back down in zero and stay at zero. Now, as a provider, okay, and obviously I'm not going to talk to the patient about this, the fact that they blipped positive, do they have a higher chance of recurrence in the future, higher risk of issues? Yeah, he showed a bunch of data points. So that's a patient that I'm going to probably follow longer than perhaps I would have otherwise. So I don't think it also it's like Wizard of Oz. You pull back the curtain as a provider and you can see this is somebody I do need to follow instead of having the blinders on and waiting for the symptomatic recurrent. Mm-hmm. Mm-hmm. So the lead time bias, yeah. So one thing that I think is a differentiator in terms of lead time bias is this. Maybe you all have great compliance with your hormone-positive patients on tamoxifen and anastrozole, and if you do, I drop the mic to you. My patients are terrible on it. I would say maybe 15% of patients have compliance. All of the studies we have learned about with surgeons with disease-specific survival, overall survival was based on patient compliance on all modalities of therapy, including anti-estrogen therapy. That's not real life, okay? So from that standpoint, I don't necessarily know, and I don't have the data to prove this, okay? But I don't know that this is a lead time bias thing because the patient never followed the whole trajectory of medical management as what the trials had projected and shown for us. So there, I think, there's a nuance to be had.
I'd like to say something about the importance of multidisciplinary management here. I work in an academic setting where the radiation oncologist just does the radiation. The surgeon just does the surgery. Surgeons do not write for tamoxifen. The medical oncologists are the one who are ordering the ctDNAs or changing the hormonal therapies, what have you not. The few times I have ventured out on my own to do this without letting my medical oncology colleague know, it has not been appreciated. And so when you sit down with the patient, to let them know you want to do this, you definitely need to have a conversation with the medical oncologist. Like Erica says, it's a team approach when when it does become positive, and you need to be on the same page in terms of giving a unified message about what the options are and what you're going to do. You definitely need that buy-in and collaboration up front, I will say. So, I've seen rad oncs just kind of randomly order it here and there. That I don't think is responsible or the best way to kind of go about this for your patient. So I think having a system, very structured one like Erica's, but where medicine is aware,
Absolutely.
rad onc is, we all follow the patients at different intervals. I don't know if you guys have a system where, rad onc sees them once a year, but alternates with surgery. The surgeon's always a CEO of all the mammograms, so they definitely see their surgeon annually, and the med oncs, are kind of wedged in there, like in between, following them for systemic side effects or hormone therapy. So I do think that coordinating that and coordinating their draws and having everybody kind of on the same page really helps when delivering that message. That part comes, which isn't so fun for the doctor, but.
That is unbelievably important. When I first started ordering this, I took my med oncs out to dinner and I sat them down and said, I'm going to do this. And I just did. And I said, I'm going to be talking to you. So we have to come together as a team to really figure this out for the patient. So at that dinner, I said, let's go through. If we have a positive, she's got a 1 centimeter grade 1 IDC and the Signatera is positive low level, what do we want our workflow to be? High level, high number ctDNA positive, what do we want our workflow to be? The goal is not to have a ctDNA, throw them at the medical oncologist and shock the crap out of them because they didn't know that was coming. That's mean and it's rude and it's unprofessional. So sitting down with them saying, what is going to be our workflow? I am going to do this. What is our workflow? We have to work together as a team to take care of this patient. I found that was much more cohesive. Everybody had the jitters in the beginning. Come on, it's a new test. Everybody's doing a new workflow. We all like just to have our continuity. But once we started to work through the jitters and to have dialogue with each other, it is now very seamless.
I'm just curious what your experience is with insurance coverage for this, if you're ordering it 4 to 6 times.
Yep, so in terms of insurance coverage, some insurers will cover it, some won't, a large majority won't. And the patients that don't have insurance coverage, they will get an EOB. The EOB will look like huge numbers, okay? It'll be thousands of dollars. I have not had any patients where it was not covered by insurance pay anything out of pocket. $0 billed to the patients. So obviously the patient's thrilled with that. In cases where there was insurance coverage, because that is starting to roll now, on this test, patients are paying about $200 out of pocket for each test.
I have 2 questions, please.
Yeah.
What the percentile of ctDNA positive before the chemotherapy? First question. The second question is, there are a linear relationship between PCR and negative ctDNA. Thank you.
Yeah. So the first question is when the test is positive before chemo. Okay. In the adjuvant setting or metastatic setting? I mean, in the neoadjuvant setting. Neoadjuvant, yeah. So, well, in triple negative HER2 positive, you'll have a positive result approximately 90% of the time. Again, associated with burden and biology of the disease, the more aggressive ones will be positive in high levels. The large majority of patients, and this is what we know about breast cancer, thank God it's generally a chemosensitive disease, levels go down more than 90% of the time, and approximately even 90% will eventually reach negativity at the end of treatment. Only 10% will have about residual disease, and those are the ones that are really at risk for recurrence. As I mentioned earlier, it's kind of like how quickly they go down that you can better elucidate who's got a better outcome than others. And then the second question was?
PCR, ctDNA.
Oh, yeah, PCR. So ctDNA, is, and actually just another article just recently presented, not just in breast cancer, but in other cancers, ctDNA negativity is not a good surrogate or not a good predictor of PCR, okay? So there will be many patients that have residual disease that will be ctDNA negative. But I implore you to think that our problem is not necessarily predicting PCR. Our problem really is trying to identify who of those residual disease are not at high risk of recurrence. And that's where this data is kind of telling us or taking us that initial plasma ctDNA time point and level is telling us that some of these patients, regardless of what the PCR or non-PCR is, their outcomes are going to be very good. So stay tuned with additional data that's going to happen on that, because that, I think, is where there's a huge unmet need. Like, too many patients are getting too much treatment when they don't need it. And as we back off certain treatments, I mean, that'll be done in the context of clinical trials. All these studies, honestly, were done, right, where everybody got the treatment. But there are scenarios where medical oncologists are getting nervous about the second part of the chemotherapy in many patients with triple negative, and some of them are not even giving anthracyclines. So what they're doing is thinking twice about it if the ctDNA levels are not looking good. If they're looking unfavorable, they're like, maybe I should give you the anthracycline. I'm going to change my mind and do it instead of just what I said initially.
They'll do it on the back end.
Or they're doing it on the back end, yeah. Mm-hmm. Yep. Thank you for the questions. Thank you so much. Well, we'll be around if you also want sort of one-on-one questions. We'll be around. Thank you for joining us this evening.